evaluation team. Marlene and Kim, do you guys want to introduce yourselves real fast?
I'm Marlene Matarese. I'm one of the co-directors of NWIC with Eric and Janet, and also the deputy director of the TA network.
And I am Kim Estep, the director for Wraparound implementation for the National Wraparound Implementation Center.
All right, so today we're going to talk about some differences in wraparound coaching outcomes and in fidelity that we see as a function of some particular types of state-level system context. So both Janet and Eric already talked a whole lot about context, so I'm going to kind of breeze through this slide. But just to reiterate, there's some research that connects high-fidelity wraparound to positive outcomes. And then there's also a connection, it's also the case that fidelity in wraparound, because of the nature of the way it works, isn't just a function of sort of having a well-trained facilitator, but that the system in which that facilitator is working also has an effect on the work being done. And so today we're going to kind of talk about one way of operationalizing those differences in this case, state-level context, by looking at differences between states where wraparound is part of a bunch of community mental health centers and states that have organized themselves as and are implementing wraparound under the auspices of a care management entity. And do you want to talk a little bit about the differences between those?
Sure. So just for a show of hands, when we talk about that language, how many of you are familiar with care management entities? Okay, how about community mental health centers? Okay. So the reason why this matters to us, and we're going to talk about this over the presentation, is that I'm sure many of you noticed that in each of the different states where you implement wraparound, right now currently it's primarily being implemented either within the context of a community mental health center or a care management entity. In the states that we're in, which we've been in about 15 different states, we've seen this pattern, and just anecdotally you could see that there were differences in outcomes as far as quality of practice when it comes to wraparound that young people and their families are receiving based on the context in which their care coordination organization sits. And so for community mental health centers, they typically provide outpatient services. They provide an array of mental health services, some of which sit within the children's system, also expand within the adult system. Care management entities are typically a nonprofit organization or public agency that serves as that locus of accountability, you see those quotes, to where it's centralized around defined populations of young people with complex challenges in their families who are involved in multiple systems. So it's really specific to certain populations versus when you look at community health centers and they're serving a wide variety of populations, using often a wide variety of different practice models to treat those young people and their families. Care management entities, there's also this, they're accountable for improving the quality outcomes and cost of care for populations that are historically experiencing high costs or poor outcomes. Okay. No, it's fine. So CMEs, again, just to dip in a little bit more depth, provide specialized support, again, around that centralized locus of accountability. They provide intensive care coordination, often using high-quality wraparound, high-fidelity wraparound. They have real-time information management systems, a commitment to outcomes monitoring and continuous quality improvement around specific populations served. These populations are typically children and adolescents with serious emotional and behavioral challenges that are at risk of returning to out-of-home placement, or they're coming out of out-of-home placements back into the community. And the ultimate goal is to make sure these young people are in communities. They're at home with families or within a community setting. CMEs typically are also reaching out to youth who are at risk of incarceration or placement in child service systems. And there's supervisory support around one practice model. And we're going to talk a lot about those differences. Again, when you look at, can you go to the next slide? We don't have one on CMHCs. So when you think about CMHCs, there's multiple practice models that they're using. There's multiple evidence-based practices. There's multiple populations. And that's where we're seeing some differences. So we're talking about NWIC, so we're going to highlight 4 different states that we've worked in. We've worked in 15 different states, so all of the data is aggregated to make sure that no one knows who we're talking about. But in all of the states that we're referencing, everyone received the same package of supports when it comes to training and coaching, evaluation support, and access to a platform where we can do virtual coaching and support. So All of our training, these are our training topics, which everyone received: intro to wraparound, engagement in the wraparound process, intermediate wraparound, advanced wraparound practice, supervision and wraparound. And currently we're in 11 states. We were in 14 states. We always have that goal of transitioning out and building that local sustainability for people to be able to maintain coaching and training without us. Did you want to talk about this?
Sure. I can cover this. So the coaching process that often follows these trainings that Marlene just talked about is facilitated by this tool called the COMET. That stands for the Coaching Observation Measure for Effective Teamwork. And this is an instrument that is looking at the skill of the facilitator, and it's designed to be used in a coaching or supervision session. So it's really designed to be part of that conversation. For our purposes today, all the data I'm going to show you, these were all completed by external NWIC experts. They do sometimes train local folks to do that, but that's not included in our data today. The scores are organized into some factors that we call key elements. I'm going to give you a couple of example items here just so you can sort of get a sense of what we're talking about. So these are 2 items pulled more or less at random out of the COMET manual.
There are 46 total.
There are 46. So here we have just a description of the skill or the ability that we're looking at. There's something like the ability to identify and extract functional strengths from the story as told through multiple perspectives. There's a little bit of an additional detail there to the right. And all of these are scored as either demonstrated. There's some criteria for awarding a score of demonstrated, or not demonstrated, and then there's some additional criteria. So all the figures that you're going to see are all going to be percentages, and that's because the way that this is scored, and so the way we're going to present it, are just versions of the percent of skills that a facilitator has demonstrated in a given session. Okay?
Can I add one thing?
Yeah.
So the reason that we worked on developing this tool was because we knew, as I'm sure many of you have experienced, that fidelity matters. And when you assess fidelity, you can get great wraparound fidelity scores using WAFIS instruments, but that didn't always translate into quality practice. And so we started out using the WAFIS tools to assess that. Are you doing a good job? Are you doing quality practice? How well are you doing with families? And we saw that there wasn't a good alignment. And so we've spent years kind of developing this tool that could assess actual practice and move towards getting to that place of quality practice so that you do have high fidelity and you do have quality practice in the best part of that package.
And it's also used specifically by the supervisors and coaches that are working with a particular organization or staff member, that these items, we can target skill development in those particular items, we can track skill attainment, and so it's really comprehensive in how we can kind of look at the data in aggregate like we're doing today, but we can also look across facilitator, we can look across region, we can look across organizations, and then we can look across the state to see how things are going and tease out some of that information.
Yeah, and so I think what they're getting at, what you may notice, is that the items are like a little wordy, they're sort of multifaceted, and that's because they're designed to be part of this coaching and supervision conversation, and so there's all these details about what constitutes high quality practice.
And in case you're wondering, it's a lot more sensitive than the fidelity tools that we've developed in this group. Probably because you have these supervisors who've been trained and coached to actually be kind of harsh judges of their own staff's skills. So therefore, it also yields a whole lot of interesting data, such as those that we're about to show.
And we're just going to give you just a taste.
Just a taste. So the bulk of this is actually going to be 3 little case studies of particular states, but first I just want to show you the results kind of in aggregate. So we have 4 states that are organized around CMEs. Those are our orange guys, they'll be orange for the whole presentation, and 4 where they implement intermediate mental health centers, and those are blue. And so we can see that total scores, as well as our 4 key element scores, are significantly higher for CME states. This is data for as long as we've been doing this, so from 2013 until something like probably February 2016. If we pull apart the items where there's the largest difference between the 2 structures, these are the first 7 or so, just things I could fit on a slide. We see things like managing conflict, supporting the team to incorporate the family's opinion, facilitating the team to find strengths, facilitating the team to respect the family's values, constructing activities that let the family lead, And we see, the two elements we see are facilitating among the diverse group of stakeholders and doing so in such a way that it's prioritizing the family vision and family choice. Do you want to talk about maybe why we would see that in a CME state?
And so when you think about a CME perspective, they're not tied to any other service or any kind of mental health model, if you will. Like their sole responsibility is to kind of coordinate care for youth and keep them in the community and partner with them utilizing this wraparound process. And so in a CMHC, there's sometimes the workforce gets a little fuzzy, or maybe they're crossing the line between wraparound and something else, or they are tied to many different projects and they just aren't able to effectively really partner in this way. And when we see these differences across these particular items, we're really looking at teaming and the capacity to build off of strengths and be, I guess, a little more creative and kind of partnering with families in a really different way. And when teaming is an expectation, we see that in a CME, they're able to rise to it, where CMHCs aren't necessarily used to doing that kind of work. When you think about community building, team building that are outside treatment teams. And so it starts to shift how they're partnering with families in that, with specific respect to, I would kind of categorize those as kind of teaming and then that strengths-based perspective and really being able to pull out some of those things with the families that they're partnering with.
So this is the reverse of that. These are the items where they're most similar. There's the least amount of difference between the two implementation organization structures. And we see a lot of things to do with underlying needs and generating need statements or distinguishing between like a service need and underlying need. And then a couple of items also about the transition process. I don't know if you have thoughts about this in particular.
And so what we see in the CMHCs is it's a lot of clinical folks that are working in that setting. And they like the notion of underlying needs. It's something that they can attach to. It's something that they're used to talking about maybe in the clinical setting. And so we see more similarity across those items related to that. And I think it's just training and kind of what they attach to. And it's also a difficult part of Wraparound when you think about the notion of underlying needs. And so not only do CMEs struggle a little bit, but then our CMHCs and our clinical staff have a different perspective.
So these are total scores. So this difference has been true every year for which we have data. But it's not sort of uniformly so. There's variation among states. I know this is a messy slide. I promise that's the point. So it's not as though we have all of our, again, CMEs are orange, all of our orange bars just way up at the top, and all of our blue states down low. There's at least one CMHC state that's scoring incredibly well. We see some CME states that are sort of dipping down into those lower scores. And so what we're going to do now is sort of highlight some of those particular states and talk about what's going on the ground there. So first we're just going to call them State A. So State A is a CMHC state, but their scores are comparable or higher than all of our all of our CME states. And it turns out they have, there are some features of the way they implement Wraparound that mirror or similar to what they do in CME states.
So when you look at State A, their leadership is really invested in the success and really invested in the CMHCs and the rollout. They collect a lot of data and analyze a lot of data around that. They also have clear policies around implementation. So they've set parameters around staffing ratios. They've set parameters around supervision ratios. They've set parameters around dedicated staff for Wraparound implementation, which a lot of CMHCs do not do. And they actually have a stronghold. It's interesting in this state, I don't want to give it away, but the state level people can almost identify every care coordinator by name. And that is amazing. And it's not a tiny state. I'm not talking, it's not like Rhode Island, Delaware kind of sized, right? I'm sorry, I know Delaware's in here. I didn't, but it's little. I don't know if Rhode Island is or not. But compared to Texas, that's a huge difference. And so in this particular state, there's a lot of oversight from the state level, and I think that makes a huge difference in implementation, as well as the policies that they've created to support quality practice and skill attainment and staff.
So now we'll look at kind of For first example, we have a CME state that at least for 2 years was very high scoring. They have sort of implemented the structures of the CME. But then after 2014, their scores fell pretty dramatically. And you can talk about why. Yeah.
So I think states typically roll out implementation efforts regionally, maybe, or they start small and kind of go to scale. And so what happens is that states really intensify that support in the beginning. They're making sure that they're investing in workforce development. There's a lot of conversations and collaborations that are happening in the beginning of implementation. And then as states start to go statewide, for various reasons, lots of things happen, but maybe workforce development falls off. It's not as steady as it should be. The collaborations are kind of falling off because people feel like, oh, we've done this. Like, we got this. We can roll this out. And what we're seeing is that's not actually true. And so when that workforce development and that support doesn't sustain, and the state isn't mindful about that, as they grow and get bigger, then we see those scores decline over time as they're growing and expanding, as they move forward. And that, ongoing monitoring is really crucial, that we can't just implement something and think, okay, we did it, now let's step out and focus on something else.
And finally, we have who we'll just call State C, who are kind of the superstars in this whole process. They have the highest scores. It's been the case in both the years that we've worked with them. But those scores, we don't see those scores universally across the entire state. So this state is divided into 4, we're just going to call them subsites. 3 of them are receiving those high scores, but in one of them, the scores are quite low.
Mm-hmm. Yeah, that one site, they're dragging the state down. So when you look at that across the state, they've had some challenges in a particular area with leadership, and so a lot of turnover at the top level, which actually doesn't happen a whole lot across the states that we're partnering with. But in that particular state, that region has had significant issues with leadership changes and supervision changes and that kind of thing. And you can see a huge discrepancy between the other ones that have had stable leadership and ongoing support versus the one where staff are just kind of stuck, and there a lot of leadership turnover really in that state.
So I'm sure you guys will have conclusions also. Essentially, what we can see here is that some of the features that make up CMEs seem to be associated with increased fidelity or with higher quality practice. You can see that they're not necessarily exclusive to CMEs, in case of state A, that they require maintenance. You can't just sort of set it in place and walk away in case of state B, and that they can vary even within a state. And I'm sure you guys have other thoughts to add.
Well, I think it's around for us why it matters. That, in doing this work, we've seen a shift. So years ago, there was a huge push towards CMEs, that we were encouraging or providing technical assistance to states to implement care management entities. There has been a shift, financing drive shifts, to where more and more Wraparound is being embedded within targeted care management. And so they're using that and embedding it within community mental health centers. It doesn't have to be a bad thing. However, like Kim was talking about, in community mental health centers, when they're implementing multiple evidence-based practices, and you have one supervisor who may have 40 staff that they're supervising, all of whom are responsible for implementing a different practice model. There's no one at an administrative level who's supervising that supervisor around Wraparound as a practice model because they're spread so far. And then you have care coordinators who are going out and they're actually doing this work as facilitators, and they may be dipping into multiple worlds. They may be facilitating Wraparound for one population, another practice model for a lower tier. They may be going into another form of practice model entirely. And so when we've been providing training and coaching, particularly within CMHCS, as we see this continue to grow and this transition is happening, it's hard. It's really hard to get a system like a community mental health center to shift the way they do business. It's hard because they have to shift the way they think about financing and billing, because they have to bill what we would say is like deeper versus lighter and broader. So you're putting more of the billing hours into a kid versus a light touch, and that's a shift in values, and the way we think about teaming, the way we think about partnering with families, the way we think about just Wraparound as a whole. It's really hard for people. Many think they do Wraparound. and they don't. And then you are trying to change that culture. And I think like when you see in some of the data, like state pay, that they have some of those things in place to where they can control for it. So we're hoping that as states start to make these transitions to embedding wraparound in community mental health centers, if that's the way this continues to go, and that's in it, that people are thinking about those things as they're implementing, to really identify a supervisor who's supervising around this practice model, who have staff that are dedicated to this practice model, to do things to where you're not using wraparound to talk about lower tiers of kids that are actually not receiving wraparound, and not calling it wraparound light, because it's not wraparound at all. That those are some of the things that, we are thinking about as we see some of this data.
And I think that our support in states that are trying to implement in CMHCs look a lot different. And we do a lot of organizational development and a lot of organizational supports in those states because the providers just aren't structured to kind of take this on. And so if you are at your state level right now and you're thinking about the funding mechanisms and how you're going to do this, make sure that it's overlaid with that evaluation and outcomes monitoring and data tracking and all of those things, paired with workforce development that's ongoing. We know staff turnover a lot, particularly in community mental health centers. And how is it that we're going to continue to support as this rolls out? Because it's not easy. And it's very intensive because we're trying to target the most intensive needs, youth and their families. And so how are we really organizing ourselves differently and having those different conversations depending on the context in which you're operating?